This is Dr. Hargraves. I'm going to talk about fluid balance and dehydration, and this PowerPoint has how to calculate maintenance solution for pediatric patients. So when we're talking about the formula, this is the classic formula for pediatric patients because we have to dose their fluid just like we dose their medications, which is by weight. So for all patients, for the first 10 kilos of any patient, we're going to give them 100 mils per kilo in 1 day or 24 hours. For the second 10 kilos, so after that first 10, we're going to give them 50 mils per kilo per 24 hours. And for anything above 20 kilos in the patient, the rest of that weight is going to be calculated at 20 mils per kilo per 24 hours. And then what we're going to do as nurses is divide that by 24 hours to get the rate that we want to set our IV pump at. So how are we going to do that? So do you understand this table? The patient's weight breaks down into 3 parts. The first 10 kilos, the second 10 kilos, and then all the rest of it. So I'm going to click yes. Okay, so the first step is to make sure the weight is in kilos. So my first example here is a patient who weighs 20 pounds and 12 ounces. In order to get this into kilos, we first have to make it into one measurement, which will be pounds. So we're going to do that here. And we're going to round to the hundredths. You can pause this if you want to. I'm going to keep going. Here's our formula using dimensional analysis. We have 12 ounces that we want to convert into 1 pound is 16 ounces, and that equals 0.75 pounds. Then we're going to add that to our 20 pounds, right? So our patient weighs 20 pounds, 20.75 pounds. Okay, and that comes to 20.75. Okay, so now we're going to convert it to kilos. You know there's 2.2 pounds per kilo, so we're going to put that into our dimensional analysis. 20.75 pounds times 1 kilo over 2.2 pounds equals 9.4 kilos. And document to the tenths. As a general rule, we're not going to do weights to anything beyond the tenths column. So now we have 9.4 kilos, which is between 0 to 10 kilos. So that's the only part of this table we need to use for this patient. Now we'll go ahead and do that math. So we have 9.4 kilos times 100 mils per kilo, and then we have 940 mils over 24 hours. We're going to divide that out, and we're going to get 39 mils per hour. Now I rounded it because we're going to set the IV pump at a whole number, not at a decimal. You might use a decimal if you're dealing with a neonate or some kind of a drip, but in general, maintenance solution does not need to run at a decimal point. Okay, so the next example is a patient who's 19 kilos. Do you still use the 0 to 10 kilos and multiply 10 kilos times 100 mils per kilo in 24 hours? Yes, we do. Okay. Then do you also add the second line and multiply the weight of the patient that's between 10 and 20 kilos, which happens to be 9 kilos in our patient, by 50 mils per kilo per 24 hours? Yes, we do. So we're going to use those first 2 lines of the table for this patient. So now we're going to do the math. And we're going to round to a whole number. And again, it's going to tell us what we set our pump at. So for the first 10 kilos of our 19 kilos, we're going to multiply times 100 divided by kilos divided by 24 hours. So we get 1,000 mils in 24 hours. Then we're going to do the second part, which is the 10 to 20 kilos. So that's our 9 kilos left. We've subtracted 10 from our total weight. So we have 9 kilos times 50 mils per kilo per 24 hours equals 450 mils per 24 hours. Then we're going to add those together, okay? So we get 1450 mils in 24 hours, and then we're going to divide by 24. which gives us 60.4, and we're going to round to 60 mils per hour. Because again, this is a 19 kilo patient, somewhere around 40 something pounds. We don't have to give them a decimal in there. So we're going to give them a nice round number of 60 mils per hour. All right, so now we've got one more patient. This one weighs 40. So calculate the mils per hour so we can enter it on the IV pump. So first we have our 0 to 10, our first 10 kilos of our patient. That comes to 1,000 mils. Then we have our second 10 kilos. That comes to 500 mils. And then we have 20 kilos left over, right? Because 40 minus 20 is 20. So for our 20 kilos, we're going to multiply times 20 mils per kilo for 24 hours, and then we get 400 mils per 24 hours for that one. We're going to add them together, and we get a total of 1,900 mils for 24 hours. We divide 1,900 by 24, and we get 79 mils an hour. So this patient who weighs approximately twice as much as our last one, right? Our last one was 19 kilos, going at a rate of 60. They don't get double. They get, because those two, the first 10 and the second 10 are always going to be the same and a higher amount of fluid. So they get a smaller percentage higher because of their increased weight. All right, good. Nice job. If you want to practice this some more, I have just this PowerPoint available to you also. So now we have a 25 kilo patient. So here's our calculations. We have the first 10 kilos, the second 10 kilos, and then we have 5 kilos times the 20 mils per kilo per 24 hours. So our total here is 1,600 mils. And we divide that by 24 hours, and we get 66.66666, and we round that up to 67 mils per hour. Okay, so this one's between our other two, right? Between our 19 kilo kid and our 40 kilo kid. Excellent. So what about maintenance fluid? Well, in pediatric settings, we almost always will give the patient an IV with dextrose in it. It is not as important in adults because adults in general have more glucose stores than pediatric patients. But pediatric patients, we want to give them the amount of glucose that they need just to maintain. So it's called maintenance, right? It's like your maintenance amount of fluid. How much fluid do you need? How much dextrose do they need? So we're going to run this continuously. Now, when we put in dextrose, what we're doing is we're stimulating the body to produce insulin. And when insulin is produced and pulls dextrose into the cells, it takes potassium with it. So we have our patient has voided, so we want to make sure they have urine output, right? So we know they're clearing the potassium. And then we will add potassium into their IV fluid. The standard amount of potassium is 20 milliequivalents potassium per liter. Could go up to 30 also. So a general typical solution is going to be D5 and 1/2 normal saline. Sometimes it's 1/4 plus 20 milliequivalents of potassium. And that would be our maintenance fluid. And that's the fluid that we run at the rate that we just figured out. So when we talk about dehydration, we have some major causes of dehydration. The most common ones are diarrhea, vomiting, and lack of intake. But diarrhea, vomiting, and burns are all oozing fluid out of the body in one way or another. So I'm going to that's why those group together. And lack of intake is like lack of supply, right? So why is it a big deal? Well, because this is what the body looks like. So if you look at our little infant over there, this is from Thought Co. If you look at the infant over there, you can see that the infant is about 75% fluid. Okay, this is telling you fluids. Some of the other pictures I might have shown you have solids on the bottom and then fluids up on the top. This one is fluids on the bottom and solids on the top, I believe. So our baby is 75% fluid. Children are in the 60 to 70 range. A female woman is 58, 59%, and an adult male is about 60%. And so what are we going to do when a patient's dehydrated? Well, we got to give them some fluid, right? So our most important thing is to get some fluid into them. Sometimes just getting fluid into a dehydrated patient turns around their symptoms, especially if it's vomiting or it's lack of intake, turns it around and they're fine once they get some fluid in. And if there's a disease, we want to treat the disease. So what are indicators of fluid status? Well, we have the ones, so I mentioned vomiting, diarrhea, right? And then we have NG tube output. So we have to watch out for that when we have a patient in the hospital who has an NG tube typically to suction. And it's usually after surgery. And it's to remove all the extra liquid from the stomach while the intestine is still like waking up from surgery and peristalsis is restarting. So, and that can be a copious amount of secretions into that NG tube. Polyuria, so things like diabetes mellitus, diabetes insipidus, where they just pee a lot, maybe giving them too much Lasix or something can also dehydrate. And then third spacing or edema, so that fluid leaking out of the central circulation into the peripheral circulation. And then I mentioned burns briefly. The challenge with burns is that the skin is the organ of the skin is no longer intact, and it's the skin that holds the fluid inside our bodies. So if you imagine you take away that layer of skin, you've got the raw tissue underneath, and it's just going to ooze out. So that's what happens in burns. This little guy is a little guy with diarrhea, dehydration, and this little girl is one that has kidney or heart failure, and she has a fluid overload. So we have to look at both sides of it. In general, this lecture is about dehydration though. Okay, so we've got our baby. If we look at the baby, one of the easiest signs to see in a baby is this sunken fontanelle. So on the top of the head is the fontanelle should be relatively smooth with the bone. You should be able to run your hand across it. It might indent just a little bit, but sunken fontanelle means really sunken down, even so low that sometimes you can actually feel the ridges of the brain. And then sunken eyes. So you might not appreciate it if you don't know the patient, but sunken eyes are an indicator. Lack of tears when crying. Well, here's the good news. Babies and kids cry. So this is a really good sign for us in pediatrics, is lack of tears. And if a child is crying and there aren't tears running down the face, then they are probably dehydrated. They're going to want to drink a lot, but they might vomit. And then decreased urine output. So how do we measure that in kids, right? We know with adults, we want 30 mils per kilo per hour, but also how many hours do we let an adult go before we say, oh, they haven't peed enough? I'm going to say it's probably at least 6 to 8 hours, maybe closer to 12. In infants and babies, it's no wet diapers in a 6 to 8 period. So it's pretty similar, right? It's no urine output in that period of time. Or having just a little urine output with dark yellow urine. And toddlers and older children, it's very little dark yellow urine. And then the other signs and symptoms we can see that are on the left side here are rapid breathing, increased heart rate, because that's what kids do, right? That's their compensation. Not enough blood, not enough fluid, not enough anything, their heart rate's going to go up. They'll be restless or irritable to start with, and that can progress to lethargy and weakness. So we like to see them awake, moving around and crying, and when they're pretty lethargic and not very responsive, then we know they're significantly sicker. Skin turgor, I don't feel like it's as indicative as it is in adults. You kind of have to pinch like near the groin on lower abdomen because they're so puffy babies. They've got such taut skin. It doesn't tent very easily. Okay, so now if we're going to talk about, let's figure out how dehydrated a patient is. So we can do that in a calculation. And you can do this in an adult also. If you know how much an adult weighs, you can do this same calculation. So we're going to calculate how much fluid has this patient lost over a period of time. So we take the original weight, so that's the last weight. Let's say it's somebody who weighs themselves every Monday. How much did they weigh last Monday? How much do they weigh right now is the current weight. And we subtract it. So that's the amount of loss. So let's say they're down 1 kilo. Okay, 1 kilo is 1,000 mils. So 1 kilo is 1 liter, and 1 liter is 1,000 mils. So then we take that 1 liter or 1 kilo, because it's weight, right? And we divide it by the original weight. And then we get the percent of dehydration. So I think I have an example. So Sarah weighed 19 pounds, 8 ounces at the MD visit last week. Today she weighs 8.1 kilos. And what is her weight loss? So first, we have to convert her to kilos, right? So we have 8 ounces for her. 1 pound over 12 ounces divided by 12 ounces is 0.5 pounds. So we're going to add it to her kilos. And then we're going to add it to her pounds. So she's 19.5 pounds. And then we're going to convert it into kilos. 1 kilo is 2.2 pounds. So we divide that out and we get 8.86. Now, you can see in my little circle over here, most of us round at the end. That's because we're standing there literally with a calculator in our hands doing the calculations, and we don't say, oh, we should round that to 8.7 kilos. We just wait and round at the end. So now we're going to put it into our formula. So we know she weighs 8.1 kilos today, and she used to weigh 8.86 kilos. So that's a loss of 0.76 kilos, which we're going to divide by her original weight, right? Because that's where she should be, and multiply it times 100, and we get 8.6% dehydrated. Okay, so that's a way to do it. That works if you have a relatively recent weight on the patient before they got sick. So what's another way we can figure out the amount of dehydration? There are charts and there are probably articles, but we've got a really nice little chart here that comes to us from Up to Date, which is a paid subscription by some experts who look at current data and articles and consolidate them into here's up to date for dehydration, here's up to date for diabetes mellitus, and different pretty common disorders and diseases. So if we look at the patient's symptoms, we can see that so our patient fell into the moderate because she was she was at the high end of moderate here. And so that means her pulse should be rapid, systolic blood pressure normal to low. Low blood pressure in kids, it's really a bad sign. Respirations are deep and could be an increased rate. She should look dry in the mouth. So as you can see, the buccal mucosa is one of the critical signs across here where you should see some change in every stage. And then the fontanelle would be sunken, eyes would be sunken, skin turgor would be decreased. Her skin would be heading towards cool instead of normal because her body is shutting off the circulation to the peripheries, saying, I need to keep all that blood in central circulation to perfuse my central organs. And that means that her urine output's going to be decreased and she's going to start to head towards listlessness and but could be irritable. Now you can see it's just a small step to get into severe. And when they're in severe, we're going to rehydrate them with an IV. When they're in mild to moderate, we're going to rehydrate them orally. And you can see in mild dehydration, there's not like super high signs. It even has a pulse of full with a normal rate and not even tachycardic. So this patient is just going to look dry, and we're going to know that they've got some history, right? So they've been vomiting or they've had diarrhea. I show you two things here, Pediatric, because that's the name brand that's been around forever. It could be another type of oral rehydration. Just make sure it's the one that it's a concentration that's appropriate. So it's the typical original Pediatric concentrations, which is the right amount of glucose, the right amount of fluid, the right amount of sodium and potassium, and maybe a couple other electrolytes that match what our blood composition is supposed to be. Because what we're trying to do is replace it with a colloid similar, but we're going to do it orally instead of IV. This little container is called is a small, you can put a nipple on it, so it can be used as a bottle or it can be used just for measuring. And then a medicine cup holds 30 mLs. So this little one holds 60 mLs. 1 ounce is 30 mLs, so it holds 2 ounces of fluid. because when we're going to rehydrate, we're going to give it to them in small amounts, but we need to give a large amount, a large volume. So if it's mild dehydration, right? So all they are looks a little dry in their mouth and they're fussy and they're thirsty, right? We're going to give them 50 mils per kilo over 4 hours. Now this comes out to a significant amount of fluid. I'm trying to remember what our kid's weight was. Let's say it was 8 kilos because it was somewhere about that. So 8 times 50 is going to be 400 mils, and we're going to give it over 4 hours. So that means the child has to take 100 mils per hour. So how are we going to do that? Well, 100 mils is a little over 3 ounces, but we're not going to give them a bottle or a container with 3 ounces in it and say, here, drink this. We're going to start off by, you can see the woman up here, she's feeding this child with a spoon. We would probably use an oral syringe that holds 10 mLs, and we would drop 5 mLs and squirt it in the mouth, and then we would wait a minute. It will probably just absorb into the mucosa in the mouth. And then we will give another 5, another 5, another 5, and we will do this every few minutes until we get to however much we've decided we need to give. So if it's 100 mils in an hour, then that's 25 in 15 minutes. So I divide it by 4. So we want to give 25 mils in 15 minutes. So every 3 minutes, we need to give, how many mils, right? Or every 5 minutes, something like that. So how many do we have to give? And we're going to plot it out. And if we're going to walk away from our patient and have the parent do it, we're going to give them either little medicine cups or syringes filled with liquid and a sheet of paper with time on it so that we can make sure it happens. Because if they don't succeed at that, we have to go to IV hydration. So that was mild. Well, mild, we would go to moderate hydration, but that was mild. So moderate hydration is twice as much. So instead of it being, instead of it being 400 mils, it's going to be 800 mils over 4 hours, which is 200 mils an hour, which is a much more substantial amount in a little kid. So we're going to do the same thing, and we're going to try and get them to take it orally. If they don't succeed, then we would go to IV hydration. This ORS on the right side there, that's World Health Organization oral rehydration solution. That's what that means. As long as they have clean water, then it should be fine. They just need to mix this with clean water. So this is helping dehydration across the world. Okay, and then we're into IV rehydration with the normal saline. So if our patient doesn't succeed at orally rehydrating themselves, we're still going to hang on to our Pedialyte and our solution and our syringes and everything because we're going to get them back to the point where they'll be able to drink. Okay, that's our real goal because until they can drink, we can't send them home until they can show that they can keep up with the dehydration. So we're going to give them a fluid bolus. Now, how do we do that? Well, and so we do it, of course, for severe dehydration and for those higher or less responsive patients with moderate dehydration. We're going to give a 20 mils per kilo over 30 to 60 minutes. Now, usually we're going to give it over about a half an hour because we really want to get, especially at the beginning, we want to get some fluid back into this body. So we're going to give them 20 mils per kilo. So again, our patient was, say she was 8 kilos, 8 times 20 is 160. So we're going to give that over 30 minutes. We're going to start an IV. 160 over 30 minutes is going to be 320 mils an hour. So we're going to spike a bag of normal saline, a 1 liter bag, because, well, first, it costs about the same as a half a liter, and we don't know how much we're going to end up giving. So we do that. We start it out. We may start at 200 for a couple minutes, double check our IV, watch it, and then increase it to the right rate. And we can repeat these boluses up to 60 mils per kilo. So I saw the most I ever saw was a child who got 80 mils per kilo of fluid for resuscitation. And then sometimes after, if they're getting that high and they're still not responding, we'll go to blood after about 60 mils per kilo. Okay. And then it's going to be something isotonic, right? Isotonic, like a normal saline or lactated ringers. Isotonic, that's the word I meant to use earlier, not colloid. Thank you. Okay, and then burns in pediatrics. So kids have thinner skin. Kids have a higher percentage of fluid versus solids, right? And then the goal with immediate first aid is to cool a burn, but don't allow hypothermia. So burns that cover a large amount of the body, you don't want to be putting cool cloths on. You can just irrigate with some saline and then start to protect the body temperature. Providing fluids for replacement is huge. Protecting from any infection, right, because it's violated the integrity of the skin. And then recognizing that inhalation injury, where they breathe in hot air, it doesn't always cause damage immediately. So sometimes you know how you have an injury and then later it swells up. Same thing in the airways. It can be a later response. So need to be really careful if you anyone who's actually in a burning building should be thoroughly checked out. And then I have the diagram here of the adult versus child. This is the rule of nines. That's calculating the percent of the body that's burned. And the big thing in kids that you can see is that the head is twice as much. So the head in an adult is 9%. That's the entire head. In a child, it is 18%. And then kids lose some of that percentage off their legs. Thank you for listening.